good afternoon to all of you. Today I have been given the task of discussing the new entrant into the field of PCI, that is drug-coated balloons. So we'll discuss where it stands in the current PCI scenario. So the PCI evolution started from plain old balloon angioplasty from 1977 onwards, went on to BMS, then on to DES, first, second and third generation DES, and ultimately led to bioresorbable scaffold, which has been partially given up and may come back soon. But we'll discuss how this evolution has taken place and where does the DCB fit into the situation. So Apurva started in 1977. Acute closure complications still was 5-10%, giving sleepless nights to the operator and risk to the patient. And the restenosis was 25 to 40%, mainly due to inadequate MLA achieved, medial dissection, negative remodeling, and new internal tissue proliferation. This led to discovery, or rather invention, of BMS, which was initially used as bailout to save from acute closure. Then it went into provisional BMS use and ultimately used to near default use of BMS because the results were comparatively better than the plain old balloon angioplasty. But still, there was acute closure due to stent thrombosis 1 to 2%, even late sometimes, and ISR remained up to 15 to 30% depending on the lesion treated. And the variety of lesion that could be treated was still relatively limited because of the high restenosis rates in complex forms of lesions. So this was more limited to type A and type B1 lesions. Then the PCI evolved rapidly once the DES was put into the market because of use in wider range of lesions. But still there are some shortcomings because you are living in metal and therefore you need DAPT for 3 months to up to 12 months or longer even in some patients. HBR patients, there is high bleeding risk patients, and those patients who require urgent surgery or there is planned surgery after the PCI could land into trouble because you have to stop the DAPT and the metal inside may not be endothelized and you can get stent thrombosis. There are issues of delivery in tortuous calcified vessels where the polymer can get stripped off, how the stent itself can get damaged. Changing the artery architecture and motility, because you put a long stent in a tortuous vessel, the motility and the architecture changes and that can lead to long-term harm. CABG sites were nullified. For example, covering the mid and distal LAD can lead to future possibility of lima being nullified. Bifurcation stenting led to side branch issues. In very small vessels, the stents themselves, because of the stud thickness, would act as space occupying lesions, and if there is a late loss, the late loss will affect the small vessels much more than a bigger vessel. The no deflow risk with post dilatation, especially in ACS STEMI patients where there is soft lipid plaque and thrombus, was a major issue with stent, and the stent results were more dependent on good post dilatation, and post dilatation aggressively in these situations would lead to no reflow. Late malapposition causing stent thrombosis was an issue, and ultimately if there was an instant restenosis either with BMS or DS, and it led to a lot of trouble, and repeat treatment is relatively difficult and requires more inputs. And ISR and MACE were still not eliminated totally. So 2 to 15% depending on the lesion, the ISR and MACE still remains even with DES use. But of course, because the usage is now gone up to many of the type C lesions, and therefore the chances of MACE are going to be higher. So where does the DCB slot in? See, POBA basically causes neoendodermal proliferation and negative remodeling, which leads to restenosis. Both these are slow processes and they require rapid tissue reuptake of the drug from the balloon, and as well as prolonged persistence of the drug in the lesion tissue. And paclitaxel was initially found to be more suited. It is a cytotoxic drug, but the absorption is faster and tissue persistence is more. There was a putative advantage of positive remodeling. This was seen in peripheral vessel balloon angioplasty with DCB paclitaxel, but the red flag of toxicity and increased mortality was found in peripheral arterial disease. The studies of paclitaxel drug-coated balloons in coronaries have not found the same increased mortality, but this is a question mark still on paclitaxel. The sirolimus has a problem that all limus molecules are having a poor uptake in the tissue from the balloon, and the persistence is also poor. So this requires a special coating technique and carrier molecules to get the limus into the tissue from the balloon. And this technology is now, this is evolving, and many of the players are in the market with limus. The advantage of limus being that it is less toxic, and if it persists long term, it has been proven to be better in regular eluting stents and probably will prove to be better with DCB also. Now, what is the technical issue with DCB? If you can consider that all DS are not same because different molecules used, different platforms are used. Similarly, all DCBs are also not the same. So there is no class effect because the pharmacokinetics and pharmacodynamics vary with the delivery systems and the molecule used. So you have to select the DCB, and according to the trial data, you have to use the DCB in certain situations. The whole field of DCB indication is still evolving, and certain things are established, certain things are still in the process. What are the advantages of DCB or BMS or DS? There is homogeneous drug delivery into the vessel wall. If you are putting a drug-eluting stent, the delivery is only at the sites where the stent metal is coming into contact with the vessel wall, and then there is diffusion of the drug into the vessel wall. So homogeneous delivery in the vessel wall, and immediate drug release without use of polymer. So you are avoiding a polymer. You are avoiding any metal in the artery, so that long-term issues of stent thrombosis, malapposition are removed, and the architecture of the vessel is maintained. The option of using drug-coated balloon either alone or in combination with the proximal DS and distal DEB is a good option. There is no specific training required. There is no specific criteria of achieving the optimal stenting. Here the balloon itself is used, and this is a basic process of angioplasty. The potential of reducing the antiplatelet therapy to almost 1 month or less, and if required in HBR patients or in urgent surgeries or planned surgeries after angioplasty, you can stop the antiplatelet agent easily without chances of acute closure of the vessel. Event rates are comparatively low, and similar efficacy outcomes are seen in certain subsets of lesions, not in all subsets, which we'll discuss further. And the most important thing is in patients with recurrent instant restenosis, say previous BMS or DS, the implantation of a new DS will result in multiple metal layers, onion skin phenomenon, and these patients are at high risk for additional recurrences or even stent thrombosis, and therefore probably DCB might be an advantage in these patients. Before going into the indications for DCB, we will discuss what is the difference in the technique usage of DCB. Very important is that optimal lesion preparation is must. Just like in patients with bioresorbable scaffolds, like Absorb, we used to do perfect lesion preparation. Here also it is very important. Sizing of the reference diameter post nitroglycerin into the coronary with or without imaging is important. Before opening and the DCB for usage, confirm that optimal predilation is taken place. So your predile balloon should be checked in orthogonal view and make sure that it is 1:1 expansion is there. The residual lesion should be less than 30%. There should be no type C or higher dissection. TB3 flow should be established and confirmed before you open the DCB and insert it. And the next step to be more sure is leave a pressure wire inside, and the resting PDP or DFR should be more than 0.9 or the FFR should be more than 0.8. It should be checked at least 5 to 10 minutes after your last balloon inflation. And once you are sure that all these 4 criteria of less than 30% residual, no high dissection, TB3 flow, and your DFR more than confirmed, then you can go for usage of DCB. Also make sure that the DCB can be delivered quickly and easily to the lesion. And the transit time from the 2E burst or the Y connector to the lesion should be minimized. So make sure that you use all necessary tricks before inserting the DCB. This can be judged by the previous balloon delivery that you found to be difficult, then you can use better guiding support, buddy wires, guideline extension, or better lesion preparation before opening the DCB and inserting it. Make sure you don't touch the balloon surface with wet gloves because the drug can dissipate from wetting of the drug. If the delivery fails for some reason or the other, then it is better to discard the balloon and use a new one because the drug will have significantly diluted in the blood and the tissue. Inflate the balloon, ensuring the proper length and diameter of the balloon selection, and inflate for at least 60 seconds and even longer if the patient tolerates better. Now we'll come to the indications. First, we'll talk about DCB in instant restenosis, which is more or less a good established indication of a DCB at present moment. ISR, the technique of PCI involves almost a mandatory use of imaging because you have to find out whether there is any mechanical cause like a fracture of the stent or under expansion or malposition of stent, which has led to the ISR. Once you have taken care of that mechanical the complication of the stent, then you can use DCB in some of the patient. So make sure you detect and manage the mechanical issue by whatever treatment modalities that is required, whether it is rotablator, IVL, high pressure balloons, or cutting balloon. Make sure there is no geographic miss of the previous stent, and then tackle that. If there is a stent fracture, of course, you will use another stent. Here, DCB cannot be used. ISR of BMS is different from ISR of DES. In BMS ISR, usually there is only neoendodermal proliferation, and the data from various studies shows that DCB is clearly better than DES and at least as good, and therefore it is established as a class 1 indication in BMS ISR. Now, unfortunately or fortunately, BMS ISR nowadays are not going to be seen because almost last 10 to 15 years we are already using DES, and therefore in our setup this is rarely seen. A good strategy in selected patients probably. So the summary is DCB only, PCI is very promising, fourth revolution in coronary interventions probably, opening new horizons. The indications may be small vessels, ISR stent delivery, or ISR or stent delivery failure, branch lesions with smaller vessels like one diagnosed PDA, PLV, two bifurcations with long side branch lesions or complex side branch ISR difficult to treat with DES. Bifurcation lesion, you can use DES main branch and DCB side branch strategy. Long segment CTOs, long DCB or focal stent with or without focal stenting can be used. High bleeding risk patients, planned surgery immediately after PCI, you can use DCB. Of course, peripheral vascular disease, it is FDA approved already from 2016. It is nowadays being used in erectile dysfunction also, not our field of course. So these are the possible indications for DCB. Thank you.